Thank you for joining me today. My name is Nikki Pettersen. I am a graduate nursing student at Norwich University, and I'm here today to discuss benign prostatic hypertrophy with you all. So what is it? What's benign prostatic hypertrophy, also known as hyperplasia? So to begin with, benign prostatic hypertrophy, hyperplasia, which will be referred to as BPH, moving forward. It's a common urological disease. It's non-malignant, hyperplastic, and progressive histopathological change in the stromal and epithelial cells within the transitional zone of the prostate. This can result in prostate nodules, inflammation, fibrosis, and changes in the prostate smooth muscle activity. So, let's see, at what age is BPH most common? So older men are commonly diagnosed with BPH. Its age-specific prevalence appears in 8% of the male population in their 40s, in 50% of men who are in their 60s, and in 80% of men who are in their 90s. So as you can imagine, no matter where you work, if you're going to work in surgery, if you're going to work as a family nurse practitioner, if you're going to work as a PMHMP, you will see BPH. It's just a commonality across the board. And what are the factors associated with BPH? So factors associated with BPH include metabolic syndrome, obesity, dyslipidemia, diabetes, cardiovascular disease, educational level, antidepressant use, calcium agonist use, a family history of bladder cancer, and alcohol consumption and smoking. So again, benign prostatic hypertrophy. The pathophysiology is what we'll discuss next. So it's not fully understood. However, several factors such as genetics, androgens, estrogens, insulin, growth factors, and inflammation play a role in the associated balance between cell proliferation in the prostate, leading to prostate gland enlargement. Testosterone-derived androgens play a role in the normal function development of the prostate via transcription factor. Androgens do this by signaling the pathway that converts testosterone to dihydrotestosterone via the 5A reductase enzyme. Estrogens act in metabolic dysfunctions. High adipose volumes lead to androgen conversion to estrogen, whereby elevated levels, which cause proliferation of prostatic stromal cells and prostatic epithelial cells. Insulin growth factors impact the prostate via IGF-1 receptors. These increase the stromal cells in BPH. All right, inflammation occurs from the proliferation stimulating T cells that release cytokines and interleukins, which serve as a potent prostate growth factor. All of these things contribute to a constant prostate remodeling process, which leads to chronic inflammation and progressive increase in the prostate volume. Okay. So here we're going to look at, here we're going to look at the comparison of the normal prostate and bladder and the BPH prostate and bladder. Starting with the bladder, you can see the wall has become thicker. Eventually, if left untreated, the bladder weakens. The subsequent narrowing of the urethra adds to urinary retention, which causes many of the symptomatic issues associated with BPH, which I'll discuss next. Just to give you a better idea, because it's really hard to just see this on the screen, here is a male in his 40s, normal size prostate. Okay, normal size prostate. Now we're going to show you a prostate, the size it can reach to with BPH. So here you have normal male in his 40s prostate. Here you have BPH prostate. And you can just imagine how this process really creates some unpleasant symptoms for your patient with BPH. So symptoms of BPH. LUTS, L-U-T-S, is the acronym for lower urinary tract symptoms. These are a hallmark of BPH and are characterized by urine retention, a weak urine stream, dribbling urine after voiding, excessive urination at night, and bladder infection. Bladder stones and reduced kidney function may also occur. Incontinence and erectile dysfunction are common in BPH. Okay, so when we're looking at the diagnostic evaluation, often starts when the male patient presents to primary care with bothersome lower urinary tract symptoms. This is where the care provider should obtain a complete medical history, so H&P, including assessment of fluid intake, voiding patterns, bowel habits, and lab work. PSA, or prostate-specific antigen, is a blood test that measures the amount of a protein made by the prostate. Values vary by age, and as such, providers will categorize that PSA level as elevated or non-elevated. An elevated PSA value can indicate BPH. Further, a digital rectal exam can indicate if the prostate is enlarged. A urinalysis with culture and sensitivity should be performed if positive for infection, as well as hematuria, as they are also signs of BPH or symptoms. The provider should also screen to rule out prostate cancer, creatinine and blood urea nitrogen, as well as hemoglobin, to rule out kidney damage and anemia that can occur from BPH. The International Prostate Symptom Score. So this is a screening tool that the provider can use to help diagnose and track BPH. A score of 0 to 7, it's considered mildly symptomatic. 8 to 19 is moderate, and a score between 20 and 35 indicates pretty severe BPH. If the International Prostate Symptom Score falls between 0 to 7, conservative management of BPH can occur with lifestyle modifications depending on how bothered the patient is by their BPH symptoms. So on a scale of 0 to 7, conservative management looks like losing weight, decreasing evening fluid intake, reducing caffeine, sugary beverages, artificial colors, flavors, and sweeteners, which are known irritants to the bladder. By practicing timed voiding, performing pelvic floor stretches and relaxation exercises, and maintaining a bowel regimen to stay regular, your very mildly affected patients may have relief. So next we would move on to medication. This is, our moderate patient. Finasteride. It's the most commonly prescribed medication to treat BPH. It works by decreasing the size of the prostate via that 5-alpha reductase inhibition. And we talked about that in the pathophysiology portion of this presentation. So finasteride comes as an oral tablet. The FDA has issued a black box warning that while finasteride reduces BPH, overall risk for prostate cancer by 25%, taking finasteride does rarely increase the number of high-grade prostate cancers. So that's part of your patient education when you're putting them on that medication. So medication continued. Women who are pregnant or may become pregnant should not handle finasteride tablets. This medication can be absorbed through the skin and cause birth defects. Finasteride has been associated with a change in mood, specifically depression and suicidal thoughts. Prescribing providers should screen for this possibility. Other common side effects of finasteride are a decreased libido, erectile dysfunction, gynecomastia, breast tenderness, and a rash. a really important part of being a primary care provider, being that family nurse practitioner, is educating the patient to the common side effects and stressing that they need to report those side effects to you immediately, even if they seem really small. It's just an important part of practice. Okay, so now we've gone conservative management. We've talked about medication. The end-all, be-all is, when you need to go to that surgical intervention, and that's really that really severe management of symptoms. So you've got the patient with a really elevated PSA, incredibly symptomatic. The radiology tests are coming back showing you that, everything's really, really stenotic in there and very swollen. And this is something that probably maybe is beyond just medication alone. So there are a couple of things. So the gold standard here is transurethral resection. It's also referred to as TURP of the prostate. It's the gold standard of surgery to relieve obstruction caused by BPH. So with a TURP, an electrified wire loop is introduced by a scope that shaves away the inner portion of the prostate. This allows for expansion of the urethral channel. Again, normal prostate, really big BPH prostate. You can just imagine what sort of symptomatic situations are going on and at what point, is it just beyond medication by itself. So the TURP is performed under anesthesia in the operating room. So occasionally you're going to have a patient, maybe history of MH, just cannot tolerate that anesthesia for whatever reason, extremely high risk. So it's not the gold standard, but temporary relief of BPH can be done via minor surgical placement of a prostatic urethral lift. This mechanically separates the prostate tissue. This can be done under local anesthetic via cystoscope in this vein. Other devices are available that do the same thing, but why it's not the gold standard is because it just provides temporary relief. So this device at some point stops working. It either has to be replaced or something else needs to be figured out. And really, when you're at this point where your patient is very severe, radiology exams are coming back, not looking great, TURP is a consideration, symptoms are terrible, you're really going to involve that urologist right away, and they're the ones who are going to make this decision surgically, and they're the ones that are going to perform whether in office or under sedation or under anesthesia in the operating room. That will really be beyond your scope at that point. I hope that you all have learned a little bit extra about BPH. Please go ahead, ask me any questions. If you want any further information, please respond to the forum and I will get back to you. Thank you very much.